My name is Dr. Kathy Marsh, and it is my honor to serve as the Associate Dean here at the Hahn School of Nursing and to welcome you to a great evening we have planned for you. I would like to begin by introducing our panelists, and we'll begin with Dr. Cherie Scott. Okay. Dr. Cherie Scott is an associate professor here in the Hahn School of Nursing, coordinator of our CNS program, a CNS herself, teaches in the program, and also a retired U.S. Navy nurse. Welcome, Dr. Scott. Dr. Christina Kelly, welcome. Dr. Kelly guides the clinical nurse specialist and senior specialist nurse educator team at Sharp Chula Vista Medical Center. Welcome. Thank you for being here. Professor Marlena Montgomery is the Chief Nursing Officer and Vice President of Patient Care at Sharp Coronado. Thank you, Professor. And our last panelist is Dr. Sharon Smith. Welcome. Dr. Smith has her Ph.D. from the University of California, San Francisco, and is currently the president of the San Diego chapter of the Black Nurses Association. Welcome, panelists. Before we begin with the questions, I would like to introduce our esteemed Dean, Dr. Jane Georges, for some welcoming remarks.
Hello, everybody, and a special welcome to my nurse colleagues who are here tonight. I'm Jane Georges, and I'm the Dean of the Hahn School of Nursing and Health Science at University of San Diego. And I appreciate so much your joining us this evening. I know many of you have come from very long days of clinical work, teaching, and research, so thank you for being here. This symposium is being made possible by a generous gift from Dr. Linda Urden, one of our distinguished retired faculty from the Hahn School of Nursing. Her gift is funding a variety of initiatives in the Hahn School designed to enhance diversity in our students, faculty, and curricular approaches. We are so very grateful to Dr. Urden for her dedication to our school and to the very important issues of diversity and inclusion in nursing education and practice. The Hahn School of Nursing was founded in 1974, so we're about to have our 50th anniversary. Since the founding of our school by Dean Irene Palmer, our school has always been committed to programs and the generation of new nursing knowledge that focuses on vulnerable populations. As a school, we have committed ourselves to the reduction of health disparities and the examination of the social determinants of health. We are at a critical point in our nation and as a global nursing community in choosing to address inequalities in nursing. And that starts with an honest and open dialogue, including the social determinants of health. There are many great schools of nursing in San Diego County, and we welcome our colleagues from them tonight. You honor us with your presence. We want our school, the Hahn School of Nursing, to become the locus of public dialogue regarding health inequities by nurses and for nurses. We're doing this by initiating a conversation across diverse communities of nurses in an intellectually open setting. We welcome diverse voices and ways of being. Our school is committed to speaking what has previously gone unspoken in schools of nursing, our own truths around issues such as racism and sexism in nursing. By speaking the unspeakable, we can begin to shape a different future pathway for nursing, both here in San Diego and nationally. And now, before I begin the panel discussion, I'm going to ask Dr. Linda Urden to say a few words to us. She is truly a pioneer who shaped American nursing in so many powerful ways. Let me tell you a little bit about Dr. Urden. She received her diploma in nursing from Barnes Hospital School of Nursing in St. Louis, one of the oldest and most prestigious of the diploma programs in the United States during the diploma school era of nursing. Her bachelor's degree is from Pepperdine University in Malibu. Her Master of Nursing degree as a cardiovascular clinical nurse specialist is from UCLA. And we are very proud to say she received her Doctor of Nursing Science, the DNSC degree, from our school, the Hahn School of Nursing at the University of San Diego. In various positions throughout her career, Dr. Urden has worked to create cultures that are sensitive to differentiated practice and ensure healthy work environments. Her research and publications have been in the areas of heart failure, ethics, research, outcomes measurement, management and care delivery redesign, executive decision support databases, collaborative practice models, and the clinical nurse specialist role. She is truly a Renaissance woman. She is a noted speaker both nationally and internationally. Dr. Urden's most recent research has focused on magnet institutions, particularly the characteristics of the role and importance of CLIN specs in elevating quality in professional nursing practice. You may be familiar with her name because she has co-edited 2 major critical care textbooks, including Critical Care Nursing Diagnosis and Management, the 10th edition, Priorities in Critical Care Nursing, 9th edition. They have been adopted extensively and have shaped the practice of critical care nursing globally. And now, it's my pleasure and privilege to call Dr. Urden to the podium. Dr. Urden.
Okay, I'm tired now. Been working all day on that 10th edition of Critical Care Nursing, literally. I do want to tell you the linkage between that book and this discussion tonight. And one of the things that we do with our books, and I will tell you about my 3 team members, Dr. Kimberly Sanchez in the back? No? Okay. Is Kim here? She was going to be coming, but she may have gotten in traffic. She's a clinical nurse specialist at CAC ICU at University of Southern California. Dr. Kate Stacy, who many of you do know, who is in Tucson now, and Dr. Mary Lowe, who's a research scientist at Stanford. What we do for each of our editions is look for a new feature. And the new feature for this 10th edition is the Social Determinants of Health. And what we are doing for that is we take the social determinants of health, as many of you are aware of it, at the macro, which comes way, way, way up here, and apply that down to critical care. So we take an issue, and the 4 of us select several and determine what we want to highlight for our particular subjects and chapters. So I'm going to just give you a quick bit of what I've done for one of my chapters. And this came from, I can't even remember now who it was, but it was one of my Ph.D. students. and we were talking about the challenges that her staff had. She was a manager, that her staff had taking care of med-surg patients, that they come in and they're addicted to some kind of abuse, some drug. And they're not in for that, but they are addicted to a drug and the problems that causes. So anyhow, that stuck with me. So here is what we're creating is like a 2-page box. And so what we're turning this into is just a vignette with what the issue is, what some interventions are, and some resources. Now, what actually happens is that these are things that cannot be resolved in critical care because they've happened. The social determinants of health come from community, they're geographic, they're community issues, they're nutritional issues, etc. So they're things that have been with people from the beginning, so it's not like we can go in and fix them. But I wanted to give you some statistics here just to give you an idea of what we're dealing with. The escalating opioid crisis affects all healthcare sectors and settings nationally. This crisis was proclaimed to be an epidemic and public health emergency in 2019 by Health and Human Services. And they reported that an alarming 11.5 million persons, all genders and ages, misused prescription medications. An astounding 20 to 50% of those admitted to hospitals possess substance abuse disorders. They're not coming in with this as the primary diagnosis. Additionally, hospitalized patients have increased comorbidities and healthcare costs and greater risk for readmissions. Those who require ICU care have longer ICU stays, higher Apache 2 scores, and higher mortality. Researchers in one study indicated that substance abuse admissions into the ICU use about 25% of resources. So you see, just because they have these substance abuse issues, this is all happening. This is not their primary diagnosis. This is not them coming in with pneumonia or coming in for surgery. Caring for these patients, of course, is frustrating for nursing staff, as there are additional needs related to the addictive disease, et cetera, et cetera. Essential is the recognition of withdrawal symptoms, such as all those withdrawal symptoms that you would know about: agitation, tachycardia, chills, flushing, muscle aches, et cetera, et cetera. So just a little snippet of what happens with somebody who has an existing substance abuse issue, who just happens to be admitted to the hospital, to the ICU, with another diagnosis, but has a substance abuse disease on the side. And then I have another one which I'm not going to read to you, but think the same thing for existing mental health issues. They're coming in for their major surgery or their trauma or their whatever they're having. And oh, by the way, they have some kind of mental health issue. So those are the things that happen when we're looking at social determinants of health and how it is macro applied all the way down to the local level. So anyhow, there you go. So next.
Thank you so much, Dr. Urden. Well, it's time to get to the main event of the evening, which is our panel discussion. And once more, I'd like to thank our panelists for joining us after, I'm sure, what has been a very long, hard day of work. So thank you so much for being here. We have put together some questions for our panelists, but I also hope this can become an open discussion, and feel free to respond or to comment on anything you think is of value to our audience here. I think it's always good to start at home, right where you are. And here we are at a School of Nursing. I'd like to start with this question. Thinking back on your professional education, what could schools of nursing do better to expand the awareness of diverse patient needs? Dr. Scott, you want to go ahead? Okay.
I've never been accused of being too quiet, so hopefully you can hear me. I'm not sure how this works. All right, well, can everyone hear me? Okay, good. I am actually really pleased to talk about this, a subject very important. And when I was looking at this question, when they sent it out, the first thing I thought of was, number one, it's been a while since I was in nursing school, but the textbooks that I'm seeing today, when I'm looking at, new med surg textbooks, still have the same things that I think we need to work on, which is we are looking at snippets of culturally competent care, right? That's the term that is used. Instead of maybe focusing on strategies, thank you, focusing on the conversations like we're having tonight. Thank you, I appreciate that. So I would like to start the conversation there, that important conversations with our students is what's most important. And I will tell you honestly, when the Future of Nursing report came out and kind of was this call to action, I was new to academia, which I still am, and I was thinking, oh my gosh, how am I going to do this? I don't have necessarily the shared life experience of some of these tough topics that we need to be talking about. And so how do I do that? How do I not say the wrong thing to our students? And so I've just had to embrace tough conversations. It's so good to see so many of my students that I've had some of those conversations with. But to answer your question, Dean, I think conversations about social determinants of health at all levels of nursing, including the bedside, that everyone has a role, can play a role, and not moving away from these presentations that can be a bit stereotypically driven, culturally competent care, and rather looking at individual situations and tough conversations that we just need to have. I'm glad I'm not the only one.
It's a little, pull it forward.
Good, mine was.
How about now?
Yes.
There we go. I think you make a great point that, and I'm happy to see these days that we're really seeing a transition from that cultural competency to cultural humility. I don't think that going through nursing school many years ago that I really felt culturally competent, and it didn't feel like the right term for what we were doing. And so I'm very grateful that we're moving away from that competency, which we're all nurses, competencies are kind of what we do, so I can see why we were going there. But I think we were wrong, and that really creating humility and a sense of interest and a sense of curiosity is how we will get there.
Thank you. Those are both very thoughtful remarks. I would like to hear from the two working NPs here about NP education.
Well, I'm not an NP, but I'm a CNS, but
Okay.
I have a couple of things, if it's okay, if I go back to
Please
that
go
question.
ahead, yes.
So when we're teaching nurses pre-licensure, and one of the things that we utilize a lot is when a person is decompensating, we say that, oh, what's the first sign that your patient is compensating, right? And you'll hear things fly out of students' mouth, like, oh, they'll have decreased LOC. Oh, they'll be pale. How do you check paleness in someone that's from Nigeria, who is the complexion of my sweater? How do you do that? That's not an appropriate method to teach anymore. Or it's appropriate for certain skin types, and you need to be very purposeful when you're having those conversations with these students. A couple of other things, and I love that you said that, Marlena, where we're saying that we need to move away from using terms like competence to humility, to inquisitiveness, to awareness. Because unless you saturate yourself in someone's culture for many, 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 many years, perhaps even decades, you will never understand what it feels like to be from that culture. So we can never consider ourselves competent. I love that you brought up the textbooks, because I had the pleasure of going into the Library of Congress last year when I was at Capitol Hill with the ANA California chapter, and I went down into the bowels of this library and requested med-surg books from the 1800s, and they look exactly the same. Okay, some of the same things that we're doing. If you go to the shock chapter, we're doing some of the same things, and the pictures look exactly the same. So we're 200 years in, and we still have people of lighter skinned who are white in the vast majority of our textbooks. So we also need to have these critical conversations, but we need to be on the front lines actually rewriting these textbooks, putting in pictures that are meaningful. Another thing that we can do, and I won't belabor this point anymore because I've got a lot to say about this, but I definitely want to get to these other questions, is the best thing that we can do for our schools of nursing is ensure that we are bringing in faculty that are diverse. Because faculty that are diverse are going to bring in diverse nursing students. Nursing students, Black nursing students, Hispanic nursing students, are largely going to be uncomfortable where their entire faculty are made up of middle-aged white women. They don't have trust because they don't see anybody in the front of that room that looks like them. Does that kind of make sense? Right? So this is a safe space, right? We're supposed to be talking about some controversial topics here. And so those are the things that we need to be looking at in our schools of nursing to ensure that we're diversifying not only what our faculty look like, but that's going to roll into what our nursing students look like. And the greater awareness that we have in making sure that our nursing student population is diverse means that we can now meet the needs of our very divergent community, right? So then it goes beyond just the awareness and the hoped competence, but you're actually sticking nurses with their people that look like them so you can build that community trust.
I think that same exact sentiment probably translates well to the hospital areas when you're talking about leaders. I do think that it's a similar focus, right? Is how do we get more diversity in our leaders? We do get to see data about our hospital, our employees, and seeing the diversity numbers improve, but when you layer it and look at where those people in your organization, we really need to focus on that growth and development and being really intentional, I think, to your point.
Thank you both. I'm reminded of a comment from one of my wonderful professors at the School of Nursing at University of Washington, Dr. David Allen, who asked a room full of middle-aged white women, a cohort of Ph.D. students, don't you get tired of being around people who look just like you? He said that in 1988, and it was a very brave thing to say, and it was a wake-up call for all of us of that generation of nurse scholars. I'd like to ask Dr. Smith, would you like to add anything?
Can you hear me? Okay. I think we need to do a better job of making our students aware of their own biases, because what I often see, and I was a clinical instructor, I had students in clinical, they make assumptions about the patient because they're Mexican, because they're African, because they're Middle Eastern. But I don't think they see the person for the individual that they are, not taking into account or consideration that, there are some intelligent Hispanics that have a PhD. There are some intelligent Africans that are physicians that, or, maybe have a PhD as well. So just see the patient for who they are and treat them accordingly, as opposed to just making assumptions because they are this race, because they're that ethnicity.
Thank you, Dr. Smith. That was very thoughtful. Now, you are an NP, right?
Yes.
Okay, I want to get it right. Okay. I'm a Clin Spec. I'm not an NP, but I have enormous respect for those of you who are. I'd like to follow up, Dr. Smith, with a question, because you do deliver primary care. In your practice, Is it even possible to use a culturally sensitive approach to patient encounters, given the limited time that primary care providers have with the patient?
I honestly have to say, I think all of my medical assistants probably are much happier on the days that I'm not there, because I take quite a bit of time with my patients for those reasons. It is possible, first of all, as I said, I try to meet my patients where they are. When I have a Hispanic patient, I can understand more Spanish than I speak, but they appreciate the fact that I make an attempt. And when they explain to me, different treatments they've tried on their own, I try to see what I can incorporate with my plan of care so that they're more willing to adhere to my treatment plan for them. It is increasingly difficult, though, because I work at different clinics in San Diego, so when I'm in East County, I see a very large Middle Eastern population. So I often ask my medical assistants, what does this mean, or how can I explain this to them, or what are some ways I can incorporate their cultural beliefs and practices into the healthcare plan. So it is possible. It does take a little bit more time, and but I feel more comfortable walking away knowing that I've given my patients something that they can work with, something that they can adhere to, and that they feel like a part of the treatment plan, as opposed to 15 minutes and we've accomplished nothing.
Thank you so much. I'd like to hear from other panelists, because everyone here is an expert clinician. How do you incorporate culturally appropriate interventions in your practice?
It's really trying to understand what would be feasible for that patient. And so you have to look at feasibility, you have to look at resource availability, you also have to look at what fits in with respect to their culture, their religion, their spiritual beliefs. Because if we don't incorporate that, there's absolutely no way that they're going to adhere to it, which is why when I see things like 30-day readmission rates, it makes me want to tear my eyeballs out, because we're so focused on that. But the reason that patients are coming back is not that the nurses in the hospital did a poor job, or the physicians or the healthcare team did a poor job. It's likely because they didn't have the access to the resources they needed within their community. And so if we're not looking at that ahead of time, and we're not incorporating a plan of care that they can reasonably and very simply adhere to, they're going to come back, period. And so it's asking good questions. I love that you incorporated your medical assistants who perhaps live and thrive in those areas, so they know what is culturally appropriate because they live in that community, to be able to incorporate that into their plan of care. Because if they can't do it, they won't. They're not going to not feed their family to buy medications to help themselves. And then they're going to end up right back in the vicious cycle of coming back into the hospitals. So when you're creating that plan of care for the students in the room, be thinking about what is easiest, what is the most feasible, and what is within their reach 20 steps out of their front door. And if that is not a part of that plan of care that you're creating, they will not adhere to it, and you will see them again.
Anyone else like to comment on that?
I just want to add on to this very important thing you just said, which is, talking to them about what is feasible, about what do they have access to. And I really want to kind of circle back around to what I do for practice these days, which is educating our nurses that are going to be in the workforce on how do we have those conversations? How do we ask, what do you have access to? And how do we ask those questions and get to know our patients in that short, limited time that we have? But how do we have to help our nursing students with some scripting, some ways in which we can approach those conversations, which may be uncomfortable if it's not a shared life experience. So, thank you.
Anyone else like to comment?
Well, I'm not practicing clinically at this point. As a chief nursing officer, I really look at this question from the lens of a hospital leader. And so all of the things that you're grappling with the students, we're still grappling with our 5, 10, 15, 20, and 30-year employees, right? Some of this stuff is new, we're learning. And so, how do you bring all of that? I think it's great we start in the schools. We absolutely must start in the schools. But there's a lot of work still to be done to get the folks that all of our nursing students are going to work with at the hospitals or the clinics, right? We got to get them also to the same place, or it's going to cause friction, right? We need the groups to be aligned. And so, I think it's important to start with hiring and just day-to-day practices to really keep that at front of mind, keep it in the conversation, keep it as part of your daily work. And it can't just be in hiring. It's got to be ongoing. It can't just be in admissions to your school. It has to be ongoing work. And I think that's the challenge that we're all going to work on for the next 20 years.
I just want to add that you are a clinician.
Yes.
That
but
nurse
farther.
leaders are the most important clinicians perhaps in the building. So don't sell yourself short. Okay. Thank you so much for these insights. Many of you know that I was caregiver for my sister, who's now passed away for some years, who had extremely brittle diabetes. And I'm reminded of the time that we went to a physician, a very fine physician, who ended our encounter by saying, "I have a perfect program for both of you." And we said, "Great, wonderful. What is it?" "It's called Project Dulce. It's for people like you." And I was a little bit curious. I thought, well, he said, "It's bilingual, it's in Spanish." And we're like, neither of us speak Spanish, and we're not Latino people. Kind of, where's this coming from? And he said, "Well, I saw in your chart that your religious preference is Catholic, so I figured you're Mexican."
Makes sense.
Lovely. Now, I don't mean to put down any of the fine physicians in our city, but I think it's an exemplar of how a little knowledge is dangerous, and how the idea of you can jump to assumptions without checking things out with patients, without really coming to an authentic understanding of their needs can happen. Well, we're going to shift gears a little bit because our school, as you know, has a Ph.D. in nursing science, and that program is geared towards the generation of new nursing knowledge through research. And we're very proud that our doctoral program in nursing was the first doctoral program in nursing south of San Francisco, created in 1984. So our school has always been on the cutting edge of creating new programs and new knowledge. I want to ask, because there's always a focus on how can nursing research help these issues you face every day. So I'd like to hear from the panelists, what areas do you think nursing research should focus on to make systemic changes in the ways in which diverse populations receive health care? And I'll open it up to any of the panelists.
I think overall, you have to do a much, much better job of the delivery of the outcomes. You have to do a much, much better job of gaining trust in minority communities. As you know, African Americans have the Tuskegee event, and I don't remember the name of the similar situation that happened in Mexico. So you have two populations that are fearful, not trusting of research. So you have to start at the very basic. You have to gain their trust. And after you've done the research, go back to those communities and share your findings with them. We also have to recruit more minorities in research, because we know that, pretty much every medication that, you give your minority patients has been tested on the older white male. And so how do we know how it works? So start at the very beginning, gaining trust. After you've gained their trust, deliver your results to them to continue that trusting relationship.
I'd like to add 2 points that I think nursing research could really focus on in this area. And the first one is more funding for qualitative research. I do think that many of the questions, if we want to talk about individuals and meeting people where they're at and being out in our community, that requires questioning, that requires talking to individuals, and it requires this really important storytelling that is qualitative research. And although my research so far has been quantitative, I value the lessons that we garner from hearing people's stories. And so, and when you look at funding announcements, it's very rarely that they're seeking qualitative research. So I think that that's one way that nursing research could really have an impact in this area. I also just wanted to add that I just lost my train of thought. I got so excited about qualitative research. Oh, geez. I will come back to my point, I guess, in a minute. But
That's okay, you'll think of it in a minute.
I will, of course.
It's been a long day for everybody here. We
Patho.
get it. Real nurses work really hard, is what I like to say.
Oh, I remember now. The other point I wanted to make was, I feel like sometimes the research around health equity and social determinants of health feels big, feels really big, it feels really daunting. And I was recently reading a study that was in the New England Journal of Medicine that was done. It was a smaller study. 319 was the subject number, and they were utilizing a strategy for hypertension in a local Black community in Southern California by training barbers to talk about hypertension, and they had brought in a local pharmacist who was also Black, and he would take their blood pressure, and then the barber would talk to them while they got their haircut about the importance of their hypertensive meds.
It's amazing.
I was like floored. This is what nursing research needs to do. Small, community-based, culturally sensitive. Let's meet people. That's how we can garner. Who are those people they trust? Let's bring them in. But it wasn't a big study, but it had a big impact.
Thank you, Dr. Scott. I appreciate your remarks, especially about research methodologies. The methodologies we choose matter. I sometimes in my classes am occasionally slip up and tell my own truth, which is my belief that nursing science has been doing the same study since 1978. And that study is the effect of social support on white middle-class women with cancer. I feel as if our focus has been essentially on maintaining the status quo when we don't ask the tough questions, both about methodologies as well as topics. And I think a community-led methodology is going to be very important for nurse scientists in the future. Well, I'd like to ask the next question, which may be a bit personal, but I hope you'll share with us, and that is, how do you maintain resilience and avoid burnout as a nurse advocate, particularly when dealing with the myriad of challenges posed by the social determinants of health in the communities you serve? So how do you do it? How do you stay resilient?
All right, I'm going to speak up.
Yeah, go for it.
Right, resiliency, this is all we talk about these days. This is like the big word this year. And I think I've done a lot of thinking on this topic because it's something that comes up regularly. And I think what's important is to, and I'm going to do a little plug here for a video you'll have to watch, but it's really to know your why. Like, why are you doing it? Why are you asking the question? Why are you there here today? Why are you in school? Like, what brought you to this place? And so I think that really goes back to your personal reasons, and how do you keep those at top of mind? And in those moments that are challenging, how do you revisit those thoughts and those reasons? And I think staying really connected to your own why and your own reasons is how you do that, and that'll carry you through. And I'll plug a little plug. It's on YouTube. It's Michael Jr. He is a comedian, and just look up Know Your Why. You will have chills. Yeah.
I'd like to hear from the other panelists.
So I'm busy from sunup to sundown, but that's why I walked in here at like 6:01. And you know, just I love, you know, answering questions through storytelling. And then the last 2 weeks, I've been to 5 conferences. So I was in Irvine, I was in Pomona, I was in Boston, and then I was in Monterey. And so it's all for, I was at, you know, the California Student Nurses Association conference. You know, I was at COADN and CACN up in Monterey. And I find myself, you know, in my car, in my hotel room, you know, asking the why, right? You have to ask yourself the why. But if I'm being really, really honest with you, the thing that keeps me from total meltdown or like spontaneous combustion is keeping a very tight, small community around myself and not forgetting to actually live, right? So that means read a book for fun, right? I'm reading like the Red Rising series right now, and it's epic. It's blowing my mind, right? Have that glass of wine. Communicate and commiserate with your people, right? And soak that up with them, where I'm not a nurse right now. I'm not a community advocate right now. I'm just CK. And I'm enjoying time. You have to set aside time for those things, or you will burn out, and the world will lose you as that spark, will lose you and what it is that you're bringing forth with regards to change.
Thank you, Dr. Kelly. I think that is so true. I have become amazed by the deep data that exists in the psychological literature that we can only show compassion to others when we have self-compassion, and we must maintain that. Anyone else want to comment on how you stay resilient?
I do, actually. I'm excited to answer this question, and I was sharing with Norma out front that I was hoping this moment would come so I could share this. I was just recently at a conference as well. I was at the Academy of Nursing. Watch her, Dr. Taibbi inducted. Congratulations. And the Lieutenant Governor of Delaware, who is a nurse, was there, and she said something that really spoke to me. And when we're tired, when we're overworked, or when I'm feeling frustrated, or why am I putting in so much effort? And I was just thinking about how being around people that are inspirational and being around, being invited tonight to sit on this panel, like that's what fills my cup, right? That's good inspiration from each other. And so I wanted to share this because it really has me going right now. But she said, speaking of nurses, that we needed to have a seat at the table, otherwise we're on the menu, right? And that's what today has kept me going. I just got to do it. I got to be at the table.
That's great.
For me, because I can't see often the results of the work that I do, and about 2 years ago, I planted succulents. I can see the results of that. And so that keeps me grounded. At the end of the day, I can go out and I see they're doing well or they're not doing so well, and so I have to adjust accordingly. But it helps me to know that I have done something, I have given back. I have produced something. And also, being outside of the clinic, being in the community, because we touch so many people that have no access to health care. And to be able to give to them in a different way, that really just inspires me to just keep going.
I'm a firm believer all roads lead to gardening, so.
Thank you all so much. Those are very, very valuable comments. I appreciate it. At this point, I'm going to ask Dr. Kathy Marsh, who's going to help us begin more of a community discussion. And we're going to take questions from the audience, and she is going to be passing the microphone around.
Professor Cassidy Creek has the microphone in the audience.
Okay.
Okay, who's got a question?
Be brave.
Hi, my name is Michael Sanchez. I'm a MEPIN in the MEPIN program. Thank you guys for being here. So my question is, in your time working at different hospitals around San Diego, what characteristics make up a hospital or organization that successfully helps an underserved or underrepresented population with regard to access to adequate health care? And what characteristics have you seen in an organization that fails to serve the same community?
Very thoughtful question. Any of the panelists like to weigh in?
I'll speak to that briefly. I think it all goes back to ethics. You really want to find an organization who lives the ethics that they say they live. And so sometimes it's hard to know until you're there if that is true. So I think you talk to the people who work there before you take those jobs. And I think that's an important thing to ask. Do your leaders, do they align with the vision, and is it ethical? What work is happening at that hospital today to improve these challenges that we're seeing in our communities? So I think it's important to ask the questions.
Great. Next question.
Hi, my name is Rachel Liu. I'm a first-year MEPIN student here at USD. I actually have a question directed towards Dr. Kelly, if that's okay. So I came up with this question with my clinical group. We were very curious to hear about your experiences, specifically at Sharp Chula Vista, in regards to the patient population there. Could you please share a project that you're particularly proud of, and what valuable lessons that you've learned from it, whether it's like giving back to the patient population or just the community in Chula Vista in general?
A specific project, well, we do a lot of projects, but I want to pick something great. Not that all of our projects aren't great, some of them are, some of them, kind of crash and burn. But one of the things that we did recently was, speaking of qualitative studies, I partnered with Dr. Julie Graham, who's a graduate of this fine institution, and we did an end-of-life study, and we're in phase 2 of that study right now. And what we're trying to garner is information about the lived experience of the family that's left behind. So it's asking them questions about what their experience was at the bedside of their loved one who's actively dying. And one of the stories that, as we were coding all of the responses and listening to the recordings, one of the things that was particularly moving was a woman was experiencing the death of her spouse, and her purse fell on the floor, and her lipstick came out of her purse and rolled across the floor. And the only thing that she could think about in that moment is, I don't have the strength to go get that, but I know I'm gonna need it, and I wish somebody would just pick that up for me. And you don't really think about like what that means until you try to unpack that. And what that let us know is that we're not focusing enough on the small stuff for the folks that are remaining after the loss and the death of their loved one. And so that's one project that is particularly moving for me. And when we first started, we were using, basically, we put the call out there that we wanted to talk to individuals. We wanted them to be a part of this study. And much like we stated on this panel, most of the folks that said, yes, I have the time, are retired, elder, white women. right? That's the vast majority of the phase one, but their stories were no less powerful. And what we're focused on in phase two is really looking at the population that Chula Vista serves, and because they are less likely to open up and talk to us, Dr. Julie Graham herself is a middle-aged white woman or creeping in that area. And so what we had to do was we're bringing in co-PIs and sub-PIs that are nursing students who look like the population served, that can go through their IRB training and assist us in those interviews so that we can meet the patient and the loved one where they are, so that we get that really golden information. And that's where we're going in phase two. And the plan for that information is to overhaul the way that we support the survivor during the death vigil, and then what happens immediately after that. Are we supporting them as they go back out into the community to try to put the pieces of their lives back together?
Next question.
Thank you, Ali Tayeb. I'm an alum of the Ph.D. program here. Actually a couple of comments. When we talk about diversity, I really want to know, academia, we talk about diversity of academics. We know there's a huge disparity from a pay perspective in attracting diverse faculty. Many of our faculty of color are first gen. They have families to support. Having them come into academia and actually taking a pay cut is a huge issue. I know from a university perspective, they have pay caps and things like that. But from a perspective of institutions that can partner with academia in closing some of those pay gaps, so universities can attract more faculty of color. Has there anything been done with your institutions? Or I know most institutions don't do that, but is that a thought for any of you? And one more comment before you answer that. When we talk about resilience, if we can talk about resilience from a spectrum perspective, because we have individuals that are on different points of the spectrum when it comes to resilience based on their own experiences and trauma. So we have to be able to meet the nurses where they are, as opposed to expecting them to perform at a certain level from across the board. So that's my really ask, is like we meet the nurses where they are versus asking them to meet certain standards that may not be the reality for them. Thank you.
Thank you, Ollie. Very thoughtful. Anyone else? Anybody want to weigh in on that?
In regards to faculty pay, a lot of my friends, former colleagues at the bedside and even in the clinic ask, why did I want to go into academia? And for me, it was about giving back. I remember in undergraduate, I met the first African-American doctorally prepared nurse, and that was the dean. And I told her one day, I'm going to be like you. So for me, at this stage of my life, I wanted to be there so that another minority student could see a minority professor in her classroom. I'm very fortunate that my husband retired from the Navy, so that subsidizes the decrease in pay, but it's definitely felt. So I appreciate that, and I do hope that we come to a day where pay is much more equitable for our minority nurses.
I can speak to that. So there's a couple of things that are going on right now at the state and national level with regards to grant funding to improve faculty pay. I'm a Black woman, and I'm the sole provider in my household, not because my husband can't work, but because we choose for him to be at home with our special needs child. And so I am unable to be full-time faculty and not have a second or third job. It's impossible for me to do that. And so there is a bill on the table right now at the national level as far as legislation is concerned to bring up faculty pay. But at the most recent conference I was at COAD and CACN, they were speaking about grant funding. So there's a few organizations up in Northern California that have applied and been given the grant money, and what they're doing with that is increasing their faculty pay so that they can attract the best and the brightest and the most diverse faculty to improve the overall diversity of their student body. So it's really slow to take off, but I think that that's something that we can look at. How can we get our faculty paid? I don't know that faculty pay will ever be where it is at the hospital level, but it's, if I'm being honest, and I know this is a safe space, it's nowhere near where what you can make as a leader in a clinical environment, and that is a huge detractor from getting folks in that clinical or in that academic setting. And I appreciate very much what you said about African Americans and other people, and I'm trying to stop using the term people of color. For those of you that don't know, that's going by the wayside. We're actually perpetuating racism in saying people of color. As a Black person, I am first gen. And so I do support the vast majority of my family outside of the people that live in my home, and that does factor into the choices that I make as far as where I need to work in order to have that income coming in. So I really appreciate your question, and we have a lot of work to do.
Thank you. It's very thoughtful. I would also like to add that as a historically women's profession, nursing academicians are underpaid in comparison to, let's say, professors in the schools of law by an enormous factor. We see this in other disciplines that have been historically women's professions, including schools of social work, library science, and education. And sometimes I think it's said that the things that women do historically, teaching, nursing, childcare, just look easy. We know they're not. And we know that we need to sometimes render our heritage salient when we speak to authorities regarding their assumptions about what nursing faculty should be paid. I once had a university administrator say, I was in a faculty meeting, not at this university, but say to the group of faculty, well, none of you are breadwinners. You don't need the same salary as the professors in the School of Law. Those types of 19th century ideas are still haunting American academia. So I believe it's the intersection of ethnicity and gender which is shaping some of this hesitance in American academia to reward us for what we're really, really worth. Okay, how about we take one more question and we'll call it a night.
Hi, my name is Ricky Lamb. I'm a first-year MEPin here, and I have a question on behalf of myself and my clinical group for Dr. Smith, but I actually wanted to open it up also to the rest of the panelists. And my question is, can you provide perhaps or share an example specifically of how you have cultivated a more diverse nursing workforce? We spoke briefly about diversity in academia and in research, but this question is specifically regarding the workforce.
I think I've had the pleasure, I would say, of working with a very diverse workforce, and to me, that's very important. Again, it's about feeling comfortable in your surroundings and your settings, and from a patient perspective. When I am at a particular clinic, say it's City Heights. In City Heights, if you're not familiar with that area, I think there's about 60, 70 different languages spoken. So when I'm at one of those clinics, it's important for the patients to see someone that can speak their language, as well as when I'm in East County or El Cajon. There's a large Middle Eastern, Iraqi, Afghanistan population there. So having that diverse workforce is very important for me as well as for my patients, because again, I can rely on my medical assistants to share from their cultural perspectives what it is my patient may be going through. And those are the rich discussions that I can have, again, when I'm formulating that treatment plan. Now, I don't have the opportunity to weigh in on who's hired or in the clinic, but I do make recommendations, and those recommendations have been taken in consideration, which is, a plus. Because again, it's important. It's important for me, it's important for my patients, because again, if we can't understand each other, if I can't understand them, and if they don't understand me, then very little is going to be accomplished in regards to their health care. So at any point, if I can, make those recommendations, we have actually 2 programs at Family Health Centers. One's for medical assistants, and we will be getting the LVN program. And I've referred several students because I know there is a need for more diverse medical assistants as well as nurses. I'm not sure how much you pay attention to the hospital settings or your clinical setting and see that, we have a large Haitian immigrant population right now in San Diego. And so they may speak French, they may speak Portuguese, they may speak Creole. So it's important that we recruit from those populations as well, so that they're able to better take care and better serve their community.
Well, I think that's a very thoughtful comment to end on tonight. As we end our symposium tonight, I would like to thank the panel for their thoughtful remarks, their authenticity. Let's give some applause, this wonderful panel. Thank you so much. I'd also like to ask for a round of applause for the organizer of this event, Ms. Tricia Guerrero, who unfortunately couldn't be with us tonight, and all our USD staff who worked so hard all day to make those umbrellas and tables and that lovely reception we have a reality. So here's to our USD staff. And in closing, I just want to say that I think the things in our lives we don't talk about can become very powerful. Historically, in schools of nursing, in our classrooms, we have not talked openly about racism and sexism. I think it's time for nurse educators to start having open, honest discussions about the power relations that shape our discipline and our healthcare system. And I think tonight we've made a start in talking about one of the most important topics for nursing education in this decade, the relevance of social determinants of health in reducing health inequities. As you leave tonight, I ask all of you, please take the insights you've heard back to your nurse colleagues and your students. We will continue to enlarge this dialogue. Please keep your eyes on our school as we enhance our focus on reducing health disparities and increasing diversity in nursing education and practice. My thanks to all of you so much for coming, and we hope to see you again soon. Have a great evening.
That concludes our program. Thank you very much. If you're interested in obtaining a continuing education unit, please make sure that you either filled out that information when you registered, or there's a sign-up sheet right out in the lobby. So thank you very much and good night. Safe travels.